today. Welcome to the NICHD's Office of Global Health panel presentation on the role of dissemination and implementation science to strengthen research in NICHD populations. My name is Janelle Walker, and I'm a health science administrator in the NICHD's Office of Global Health. And just a few more housekeeping notes. You've seen these a bit earlier, but remember to keep your microphones muted and your videos off to conserve bandwidth. Also, please to disconnect your VPN to help prevent bandwidth issues. And as we go along, please feel free to enter any questions or comments into the chat box, and questions from the chat will be addressed in the Q&A session. And also a final note that the panel is being recorded. So the purpose of this panel is to provide an overview of implementation science as a research methodology, to present examples of the benefits of implementation science for NIH research, and to share dissemination and implementation, D&I, training opportunities, followed by a Q&A session. And so one of the overall goals really is to foster conversation about D&I at NIH and gaps for future research funding. We originally planned for the panel specifically to be for NICHD staff, but quickly learned there was broader interest across NIH, so we expanded the panel to include a larger NIH audience. And so although we may refer to NICHD populations throughout the presentation and different scientific areas, we recognize that other institutes and centers are working with these populations and research areas. So we look forward to considering together how we can use implementation science to strengthen our research efforts. And as we go through the panel, just a little challenge question just to consider how we can consider implementation science at all levels of the scientific process, from basic science to clinical research to translation and to dissemination and implementation research. So just challenging you to think about possibly a real paradigm shift for science from bench to bedside and then on to the global village. So today we'd like you to think about implementation science and really how it can act as a bridge for research, practice, and policy. And I want to thank you for completing the poll questions. And I'm going to go ahead and share these results for you. And so you have an idea of who we have within our presentation today. The first question, what is your level of experience for dissemination and implementation science? And you can see the highest is about some knowledge, and then we have some none, and good, and very good. And we have a few experts in the room as well, so for that as well. And then the second question, how often are you involved with dissemination and implementation science on your job? And you can see here, mostly sometimes, which is great to hear, rarely, never, and then the least at always. So just kind of give you an idea of where who's on the panel and where we're at with dissemination and implementation science. And thank you for participating in that poll. And we are going to go ahead and move right into our presentations. We are excited to have two NIH presenters today. Dr. Gila Nita, who's a program director for implementation science in the Division of Cancer Control and Population Sciences at the National Cancer Institute. She will provide an overview of implementation science and Trans-NIH initiatives. Second, we'll have Dr. Dara Blackman-Demner, who is a health scientist administrator in the Office of Behavioral and Social Sciences Research. She will present on dissemination and implementation science training opportunities and future directions. Next, we are pleased to welcome two of our NICHD grantees. Our first presenter is Dr. Roshan Bastani, who is professor in the UCLA Fielding School of Public Health, director for the UCLA Kaiser Permanente Center for Health Equity, and co-director for the UCLA Center for Cancer Prevention and Control. She will be addressing obesity in preschools through a multi-level system-focused intervention. Our second presentation will be from Drs. Kenneth Scher, who is a professor in the Department of Global Health at the University of Washington, and Dr. Quinhas Fernandez, who is from the Mozambique Ministry of Health and Department of Global Health at the University of Washington, and they will present on implementation science to close the no-do gap in maternal, newborn, and child health. And we will go ahead and move to our first speaker, and we'll do that shortly.
Thanks, Janelle.
Thank you.
You're bringing up the slides, I'm guessing.
Yes, we'll bring it.
Thank you. And so while you're pulling those up, so I have about 12 minutes to talk, and in that time, like Janelle said, I'm going to give you a very brief orientation of implementation science and describe a set of Trans-NIH funding opportunities in this field.
Yes.
And yeah, no worries. And actually, you know, the slides aren't that interesting. So
no, they are interesting. They're great. And we are coming up here shortly.
Yeah, no worries. And I'm excited to hear from Dr. Bastoni and Dr. Scher about their work too. So great. So you can go to the next slide because I just said this one. Thanks, Janelle. And so I'm going to start with, you know, briefly, what is implementation science and why should we care? So on the next slide, I just want to start with definitions. So you can go to the next slide, Janelle. And with those definitions, just to distinguish implementation science from implementation practice. So in implementation practice, this is the use of evidence or interventions, whereas implementation science is the study of the use of evidence and interventions. There have been a few nuanced ways that the field has defined itself, but essentially you can see here that implementation science is defined as the study of methods to promote uptake of evidence-based practices or interventions in a variety of settings. So on the next slide, I'll talk a little bit about why we should care. So starting with, we don't really have to look beyond this very moment to recognize why implementation science could matter. Just take our everyday lives for the past year, and specifically looking back to the end of 2020 with the promise of not just one, but two, and now as of today, 3 highly effective vaccines. It was a rare moment of hope back then. We thought it was a turning point in the pandemic. But on the next slide, you can see we all know what happened next. The rollout has been slow and complicated, anxiety growing. Shots are slow to reach arms as those final steps of ensuring that vaccines are delivered were left to beleaguered states. So I think a nice summary of that problem is on the next slide. Ashish Jha, now Dean of the Brown University School of Public Health, and probably no stranger to any of you who've been listening to the news for the past many months, he really nicely articulated the problem, which was that at that time, the federal government saw their role as getting vaccines to the states without considering what supports states would need to get vaccines to the people. And this type of problem isn't unique to COVID-19. So on to the next slide, the promise of any effective innovation that our science delivers can only be fully realized through its use by a range of stakeholders. So how do we do that most effectively? Is it A, not thinking about implementation, not having a plan? Is it B, thinking about implementation and having a plan that's informed by intuition? Or is it C, thinking about implementation and having a plan that's informed by empirical evidence, which is what the field of implementation science seeks to generate? So this next slide illustrates what happens if we don't also focus on implementation. What this displays are findings of a study from 2000 by Andrew Bayless and Sue Boren that asked the question, let's assume that the end product of our research is just an effective innovation, a high impact publication that shows the results of the efficacy or effectiveness. What would happen next if we didn't do anything more than that? So what you see in the middle of this slide is the rough publication pathway from publication of our original research to implementation, which they defined as 50% uptake. On the left side, you see all the ways we lose valuable evidence. And on the right side, it's an estimate of how long it takes to get through each of these steps. And if you advance, Janelle, you can see that their conclusion was it takes 17 years for only 14% of original research to benefit patients. So it shouldn't be the case that so little takes so long, and move back one before we get there, and that's the time to just reach 50% who could benefit. So yes, now moving on, as you saw with the COVID-19 example, the problem does go beyond the strength of the evidence for effectiveness. An intervention is going to be only as good as how and whether it's adopted by different systems within different communities. But also not just that it's adopted, but we can make sure that we've identified practitioners who can be trained to deliver the intervention. But not just that, we know that we have a history of training where providers can't then come back and have the supports needed to actually deliver it or integrate it into the practice. So we need to make sure we're thinking about that as well. And not just that, but that we also are considering what needed supports those trained practitioners would be able to use to then reach all the populations who could benefit. So moving on to the next, even if we get halfway there at each of these steps and not even considering all the issues we would have with access, adherence, dosage, and maintenance, we're still down to just a fraction of the benefit we thought our promising intervention was going to have. So we need to make sure we're considering all of these steps. And putting it another way, you're reading my mind. Yeah, no, that's great. Go ahead to the next slide. This comes from the RE-AIM framework, which nicely articulates the goals of our field. So these are the other dimensions beyond effectiveness that we need to be considering. So how do we develop organizational support to deliver the intervention? How can we ensure the intervention is properly delivered and can be maintained over time beyond the scope of a study? And how can we ensure it reaches everyone who could benefit? So these are some of the research objectives of the field of implementation science. So moving on and returning to definitions, I wanted to highlight how we use these terms. And these come from the Trans-NIH funding opportunities I'll be describing momentarily. But we see implementation science as bridging the gap between research and practice and policy, as Janelle highlighted nicely at the start, by building a knowledge base on how evidence can be most effectively communicated and integrated into practice. So for the purposes of our funding announcements, we break it down into two different components. Dissemination research is the study of the targeted distribution of information and how best to spread or sustain knowledge and evidence, whereas implementation research is focused on what strategies can best facilitate the adoption and integration of that evidence into a given practice. So on the next slide, and digging a bit deeper, the goal of dissemination research is to understand how, when, by whom, and under what circumstances evidence spreads. So focusing on all the stages of evidence from its creation to its reception. And these are important steps that we often take for granted, but we realize we can do a better job. So in implementation research, we try to draw a contrast from what we see in typical effectiveness studies, which tend to focus on the what. What interventions can improve health outcomes? Most studies assume that if we focus on the what's the vaccine, what's the answer we need to fix the health problem, we assume that we'll get the answers that we need. What do we need to do for these individuals to improve a range of health outcomes? But what we jump over is this important middle, and that's the question of how. The implementation strategies that will support the ability of those interventions to be delivered and ensure their delivery in a whole variety of settings in which people are seeking care. And so how do we know those strategies are working? We also need to focus on the intermediary implementation outcomes. So if we get implementation right, if those strategies are working, we should see that our strategies are supporting the feasibility of our interventions, that they are ensuring that our interventions are delivered with fidelity, that they are acceptable to the populations using them and receiving them, that they can be sustained over time with high rates of uptake, and that we're also understanding the costs given the resources available. So when we start to focus more on implementation science, what we are ideally seeing beyond effectiveness is that we can have an influence on those implementation outcomes, which helps to ensure our interventions have the intended population health benefit. And understanding these strategies and what works can help to inform future implementation efforts beyond the scope of a single study. So going back to the vaccine example, and as Janelle nicely put it, building the knowledge base that can help us across the institute, centers, and offices at NIH, we hope that we can build this knowledge base to have empirically informed implementation plans. So on the next slide, I just wanted to clarify what we mean by implementation strategies. So these are the strategies we use to ensure or enhance the adoption, implementation, and sustainability of an intervention. So these include things like strategies to educate or train practitioners, to adopt and deliver interventions, as well as strategies to ensure that they can incorporate those interventions into their workflow or integrate them into their communities. So strategies to support the fidelity as well as inform how to most effectively adapt those interventions and implementation efforts to fit within a given context. So how would you select those? It will depend on the barriers you're trying to overcome and understanding those barriers, understanding how to overcome those barriers with what resources you're able to leverage, and considering who are your stakeholders. So in implementation science, we recognize the importance of context and the multiple levels of context that can influence our ability to deliver effective interventions. So moving beyond the interaction just between that practitioner and that consumer, we need to consider all the levels in which that relationship exists and how those different levels can affect implementation. When we've historically ignored these levels, we leave out populations who don't have as good access to care. So how do we best get organizational change? How do we best get communities and states to support the implementation of interventions? Moving on, you can see it's particularly important to engage critical stakeholders and build the evidence base to support implementation at each of these levels. So to the funding opportunities on the next slide, since 2006, NIH has been funding implementation science through a set of Trans-NIH funding opportunities. Currently, as of last week, 22 institute centers and offices are signed on. Before that, it was 21. So the population is growing, and about 300 grants have been funded over the history of these funding opportunities, possibly more. In addition to these three funding mechanisms, we have the R01, the R21, and the R03. There is a standing study section, which is now called the Science of Implementation in Health and Healthcare, and they have their appropriate expertise to review these grant applications. Over a dozen have been funded by NICHD alone, and I know Dara will be describing that in a bit, but I just wanted to highlight the purpose of these funding opportunities is to support innovative approaches to identifying, understanding, and developing strategies and testing those strategies for overcoming barriers to the adoption, adaptation, integration, scale up, and sustainability of our evidence-based tools, interventions, etc. We also recognize there's often a benefit to understanding circumstances that create a need to stop or reduce, aka de-implement the use of interventions that are ineffective, unproven, low value, and harmful. So that's also an area that we've highlighted in these funding opportunities. And while Dara will describe more, I did just want to mention there are also sample funded grants, and Janelle, you can advance one more time to see that of those 22 institute centers and offices, the scientific lead at NICHD is Marian Costa-Thomas, who I know you'll be hearing from momentarily. But there are a variety of staff. If you're not targeting NICHD, you can see who those others are. And on the next slide, I encourage you to take a look at those PARs. And if you Google PAR-19-274, you'll get it. But I just wanted to highlight some selected research questions that we are encouraging folks to explore. And these include a focus on understanding adaptation, understanding which strategies work best and how they work, understanding how to effectively sustain and scale practices, and also strategies to de-implement practices that are not evidence-based or are harmful. So I'm eager to hear, Dara will tell you more about the NICHD portfolio and other work, and you'll hear from some of those funded investigators. Thanks for your time.
Okay. Good afternoon, everyone. Let's see. Okay. Thank you, Gila, for setting the stage nicely for my presentation. As mentioned, I'm Dara Blackman-Demner from the NIH Office of Behavioral and Social Sciences Research. And I am excited to be here with you today, and thanks to Janelle and Marion for inviting me to speak with you today. Doesn't seem to be letting me advance my slides. Oh, there we go. Okay. So I'm going to try to cover a couple of different topics, which may not be completely flowing together as nicely as we would like, but I will do my best. So first, as Gila noted, I'm going to share a little bit of information about the general portfolios of D&I research at NIH. I'll talk some about training opportunities, and then I'll close just setting the stage for some sort of future directions and emerging opportunities in the field of implementation science. So as Gila mentioned, through these program announcements, there really has been a wealth of growing investment over the years in D&I research. And as she mentioned, a number of institutes and centers are participating. But essentially, there really has not been a coherent way to fully present the entire science portfolio at a NIH-wide level. So certainly, you could and has been done to look at the grants that, as Gila mentioned, were reviewed at the now Science of Implementation in Health and Healthcare study section, formerly known as DIRH. But it is the case that many ICs also have dissemination or implementation funding announcements that they put out that are separate, that are reviewed by a special panel or in-house. And so it has been a challenge over the years to really be able to fully articulate this portfolio. And because of this, a group led by OBSSR, but with participation from a number of people that I see are on the call today, including a number of NICHD staff who helped us with some of the hand coding, we conducted a portfolio analysis last year. And that really set the stage for what I'm excited to say is that there will be a new RCDC term that will start being developed in 2021 for dissemination and implementation research. And I think this will be a really wonderful contribution to really allow us to get a fuller sense of the portfolio. So those of you who are involved in this work, you should expect to be hearing from RCDC shortly, as we will definitely need subject matter experts to participate in that process. Okay, and next, as mentioned, I wanted to just go ahead and give a brief, give you a flavor of some of the grants that NICHD has funded through these mechanisms over the years. The ones that are highlighted are obviously the speakers that we're all excited to hear from later. The program officials listed here are the ones in Reporter, so they may not be completely accurate, but I put them there just to give you a sense of the different branches of NICHD that may be holding some of these grants in their portfolios. And as you can see, they really do span a range of topic areas across a variety of settings in populations. And I just want to call attention to a couple of other efforts that I know involve implementation science that NICHD staff are involved in that aren't represented there. And I'm sure there may be others. My caveat is these I am aware of because I happen to be involved with them. And I'll say more about AHISA later, but this is a Fogarty-sponsored network, the Adolescent HIV Implementation Science Alliance, that really seeks to facilitate capacity building and implementation science for HIV prevention and treatment in low and middle income countries. And also the PATCH Consortium that Sonia Lee, Bill Kapagianis, and Nahida Choktora are involved in. And that is similarly in adolescent HIV prevention and treatment for adolescents in low resource settings. And this project, even though implementation science is not in the title, it's definitely been a central part of the work of the projects in this network. And in fact, we just finished a 2-day meeting where the majority of the work and talks were really about how to integrate implementation science into these activities. So as you can see from this portfolio, some of the areas that are currently represented by D&I science in the NICHD portfolio include childhood obesity, maltreatment and dating violence, pregnancy and postpartum maternal and infant health, and as I mentioned, global HIV treatment and prevention. But certainly there are a number of areas and populations and priority areas that there might be future opportunities for growth in the support of implementation science. So I'm going to switch gears again and now talk a little bit about training, starting off with talking about NIH-sponsored training. So back in 2011, OBSSR, NIH, NCI, in partnership with the VA, started the Training Institute for Dissemination and Implementation Research in Health. And that was really started at the time because there was a real lack of training opportunities that were available to investigators in the field who were interested in developing expertise in this area. It was started as a week-long in-person summer institute and evolved over time to be more of a hybrid with some online and some in person. And of course now is all online. Over time, a number of ICs became involved. And this program was actually sunset in 2019, in part because of the number of increasing opportunities for training that emerged in the field, which I'll say more about in a minute. But I did want to highlight a couple of still ongoing NIH-sponsored training opportunities. So the first is TIDRC, which is TIDR led by NCI that's specifically focused on cancer research. And they do have one of those programs is modeled after that TIDR mentorship model where people work with mentors to develop concepts. With the idea being that at the end, they would be able to submit a hopefully fundable research grant to NIH for dissemination and implementation science. But they've also created the open access version, which I would encourage anyone to take a look at and share it broadly. It is essentially, it provides all of the lectures and readings for those courses, and it's available to anyone. And even though it is listed as TIDRC, many of the resources there are broadly applicable across a range of diseases. Two others I'll briefly mention is the Implementation Science Scholars, which was funded recently by OBSSR with co-funding from ODP and NIDDK, focused on chronic disease and health inequity. And the Implementation Research Institute, which has been more longstanding, funded by NIMH and NIDA, focused on mental health and substance use related issues. And both of these follow that same mentorship model. As I alluded to, over the last decade or so, there's really been an explosion of opportunities, and now there's pre-doctoral and postdoctoral fellowships, there's graduate courses, there's certificates, master's and doctoral level degrees, even in implementation science. And at the end, I have a slide that has links to all of those resources. Okay, I'm gonna shift gears again, and just for the rest of my brief time, I'm gonna just talk a little bit about some of the directions of the field of implementation science generally that I think may have important relevance or implications for thinking about maternal and child health. So obviously, I think we're all aware of the current shifting landscape of public health research and the dual pandemics of COVID and issues related to structural racism. And here I've highlighted some of the potential impacts on maternal and child health, which certainly will be familiar to those of you from NICHD, ranging from impacts on maternal mortality and obviously impacts related to school closings and as well as missed preventive care for children. And I think this is really just part of an increasing recognition, as Gila started off her talk with, of the potential opportunities to leverage implementation science to improve public health generally and maternal and child health specifically. So one of the first areas that I think has been given a lot more attention within the implementation science space is this idea of community engaged research. If we take a step back and we think about it, there's this understanding that actually community engaged research and D&I research share many similar end goals. They recognize that to achieve broad sustainable use of a program or practice, you really need to have, as Gila had on one of her slides, that stakeholder buy-in, stakeholder engagement. But the reality is each of these are essentially separate research traditions. They have their own theories, their own methods, their own emphasis, and they've really been sort of somewhat separate in terms of their NIH support. And I'll give a shout out. I know some of my OBSSR colleagues are on the call, and they led a CBPR study a number of years back that found that most of those researchers would identify themselves as health services or translation related research, but not D&I research. But that being said, in the last couple of years, there's really been a movement to better integrate these fields. And so there's been special issues and papers written. The CTSAs, which we all know have a really long-standing groundwork in community engagement, have really begun more significantly working to integrate dissemination and implementation science into their work. As well, just a couple of other examples. I mentioned AHISA earlier. We're all familiar with the RADXUP initiative, which I think is another nice example of bringing implementation science methodologies into that effort, which really was focused on community engagement and true partnerships. I think that Chris Gordon is on the line here, and he, along with a number of his NICHD colleagues, have been really instrumental in thinking about ways, as part of the Ending the HIV Epidemic work, to be providing supplemental awards for the CFARs and the AIDS research centers to bring more rigorous implementation science into these ongoing community engaged research efforts. Another area that's been getting increasing attention is thinking about how health equity fits into all of this, and an increasing recognition that this type of stakeholder engagement and true community partnership is really necessary to ensure that the research that we're all conducting is ultimately able to address social determinants of health and impact population health and health equity. And a couple of other examples of some recent thinking and papers around how we can better integrate implementation science and health equity, including a blog written recently by April O from NCI on this topic. And finally, the area of policy implementation science is one that is being really engaged and thought about more. And that's really thinking about the study of how implementation science can contribute to understanding the translation of evidence to health-related policy in a variety of sectors. And here I'll call your attention to a recent 5-part webinar series that I believe just concluded yesterday, sponsored by NCI, that really explores this emerging area of policy implementation science and how we might be able to better support it moving forward. And as I move towards closing, I just want to mention a couple of other emerging opportunities in implementation science. Most of these Gila already mentioned. There's been an increasing recognition of the importance of de-implementation and how some of the processes involved there may be different than implementation, and really thinking seriously about that, as well as ongoing questions around adaptation and sustainability and scale up. And I want to also mention this idea of thinking about what lessons we can learn from global health research. And in particularly, Fogarty is engaged in some work around this idea of global to local, and how can we take lessons learned around programs that have been developed and implemented in low resource settings globally, and potentially bring them to the US, and in thinking about implementation science questions along the way. And I will close with just, again, I think these slides will be made available, but a couple of general resources from NIH, as well as some widely available lists that sort of catalog the range of training opportunities in D&I science. And this is just a snapshot here of the NCI Implementation Science website, which I would encourage you to check out if you have not already. It has a wealth of useful information there. And with that, I will stop. Thank you.
Hi, I'm Roshan Bastani. Can you hear?
Yes, we can hear you, Dr. Bastani.
Okay, great. So I'm Roshan Bastani from UCLA, and I'm going to be talking to you today about an implementation trial funded by NICHD that addresses obesity among very young children. I'd like to acknowledge that Dr. Paul Chung and I are multiple PIs of this trial, and also acknowledge other co-investigators in this work, several of whom are on this Zoom today. And most importantly, our community principal investigator, Dr. Susan Savage. And of course, we'd like to thank NICHD for having invested in us. I won't repeat this because Dr. Nella took us through this, but this slide shows that in order to achieve population impact on the very right side, it's really important for us to move our research collectively beyond observation, correlation, into the realm of intervention research. And within the realm of intervention research, move quickly beyond efficacy and effectiveness to start conducting implementation and dissemination research. So the trial I'm going to talk about is in the implementation realm, conducted in a real world setting. Very important to have collaboration with a community entity that is going to implement the intervention and sustain it beyond the end of the grant period. Another difference between efficacy, effectiveness, and implementation is that the implementation research allows for adaptations, which make things even more messy, versus strict adherence to a protocol. And also the effect sizes that we're going to see with implementation science or implementation research are likely to be much smaller than what you would see in a tightly controlled setting of an effectiveness or efficacy trial. So our study is conducted in Los Angeles, and just a quick overview, it's down here in California, very small geography, but very huge in population. It is the most populous and diverse county in the United States. And if Los Angeles County were a state, we would be the 9th largest state in the nation. 74% of our population consists of ethnic minority groups. Latinos are the largest group with 49%. 45% of our population, adult population, is foreign born, and 57% speak a language other than English at home. Now, although Latinos are 49% of the population, what this slide shows you that it is a young population. About 70% of children are Latino versus 49% of the entire population. So because it's a young population, it is not yet represented in the older age groups to the extent that their numbers in the population might suggest. The ages at which chronic diseases start becoming more and more prevalent. So the question in terms of population impact is, do we wait for this young Latino population to grow older, get chronic diseases, and then start worrying about how we're going to fix that? Or do we move to earlier stages where we could try to prevent the chronic diseases from actually occurring by focusing on addressing some of the risk factors? And of course, obesity is one of those risk factors that is responsible for many, many chronic diseases listed up here, as well as responsible for early onset of many of these chronic diseases that we're seeing. Obesity, as we have learned over the years, is a very hard problem to tackle. It's very hard to get adults to lose weight, and it's even harder to maintain that weight loss over time. And so there's a recognition increasingly that obesity prevention interventions need to shift to younger age groups. In the nation, as well as in LA, low-income Latinos and African Americans have the highest obesity rates. This is a disparity, and we're trying to address that. And what you see here is some work we did before we submitted the R01. We did a pilot study in 100 preschools in Los Angeles and found that a very large number of children, 38%, as well as teachers and parents, were overweight and obese. It's a very important problem and a big disparity. So this is an implementation trial, of course, and our partner in this is Child Care Resource Center, which is a large nonprofit organization that serves very large numbers of children in preschools. They support about 1,500 preschools in the Los Angeles area. And more importantly, they are part of a very large national network of 700 child care resource centers. So this really is important because if the intervention is effective, there is potential for large scale ramp up and dissemination across the nation through these CCRCs. In Los Angeles, about 65% of the children served by our CCRC are Latino, Black, or Asian. And CCRC offers workforce training and development to these preschools and does it through a model of coaching. And this coaching, the coaching staff regularly spend time in the preschools and provide one-on-one support to the administration, to the teachers, et cetera. And so our study utilizes this existing resource and infrastructure and utilizes their coaching model to deliver our intervention. So the study is a cluster randomized implementation trial in 60 preschools located in the northern part of LA County, as shown here. Our primary outcome is child BMI Z-score, height and weight measurements. We have a number of secondary outcomes at the level of the child, as well as teachers and parents, and then at the level of the preschool. As Dr. Nella mentioned this, we assess implementation. It's a very important part of our work, and we utilize the RE-AIM framework, and I'll get to that a little later, to assess implementation. On the right side here of this slide, a little more detail on our trial. So it's a stratified random assignment of preschools, stratified by size and a few other variables. 30 intervention, 30 control schools, baseline data collection, school level intervention begins, and the intervention continues over time. This is not something you start and stop in 2 weeks. It's an intervention implemented within the preschools that continues over time. And while that's happening, a very big focus on implementation assessment, and then follow-up data collection at the end of the school year, as well as some focus on maintenance. This is the conceptual model that we use, our Healthy by Default framework, which essentially says that you are much more likely to get people to adopt healthy habits if the healthy option is the default option. You don't have to make a choice, it's just there. So for example, if your building does not have an elevator, you just have to climb the stairs. That's the default option. And that is much easier than giving people the choice, do I take the stairs today or do I take the elevator? So in this model, on the left, we show the intervention, which is multi-level, implemented the entire preschool level, starting with school policies on nutrition, physical activity, screen time, and so on. Changes in the school curriculum, what is actually taught every day, all day in the classroom by the teacher, to incorporate physical activity and nutrition lessons, getting teachers to model healthy behaviors and a good level of parent involvement, because that's very important to sustain the changes at home. We skip now from the blue boxes to the green side. We expect this preschool intervention to create intermediate changes at the level of the school administrators, teachers, and parents. So if we do this well, then we should have better knowledge, attitude, self-efficacy, and so on among administrators, teachers, and parents. We also expect the school environment to have changed in terms of policies they have regarding healthy eating, curriculum, menus, physical space, etc. And then both these should result in changes in the child in the middle, healthy eating and physical activity, which then should lead to positive outcomes in child BMI. However, this stuff on the right side is not going to happen unless the interventions that we put into place are implemented at a high level of quality. That's why it is so important to measure implementation. So if the intervention didn't work, was the intervention bad, or was it because it wasn't implemented the way it should have been? We use the RE-AIM framework in this work. And I'm not going to go through each one of these, but for each element in the RE-AIM framework, we have definitions, and then we also have measures that we have developed for each one of these. And I'll just do a couple. So REACH might be % of eligible preschools that were invited that actually accepted our invitation, or at the level of the school, the proportion of parents that were asked to allow their child to be measured that agreed. Or implementation might be the intensity and frequency of implementation of each of the elements. So this is our multi-level intervention, which is delivered by coaches at multiple levels. So beginning with changing policies. So instead of allowing cupcakes for birthdays, share a book. Classroom practices. So family style eating, which of course, we can't do during COVID anymore. Teachers eating with the child. Changes in the curriculum, supplying them with a resource. Sesame Street Healthy Habits for Life, which is free, very simple, can be adapted, fun. And then of course, parent engagement, cooking together, coming into the classroom, and so on. Of course, COVID happened, as we all know, and many of the intervention elements and data collection modes had to be changed. For example, no family style dining, no in-person parent engagement. We couldn't do on-site observations of implementation. Moved to virtual modes for both the coaching, which actually can work very well as for parent activities. We had to make some changes in our data collection, including how many questions. We added some COVID-related questions. We asked questions about food insecurity, which is an important issue in our communities. Here is a project timeline and shows you kind of what happened with COVID. The top here, the dark blue, is the first cohort that we recruited, and COVID-related disruptions took place just after a baseline assessment and as we were implementing our intervention. Our planned follow-up assessments were disrupted as well, and we had to push that back. We began recruitment of our second cohort because things started to improve a little bit in Los Angeles. And then over late November, December, we were hit by a really, really bad surge, and a lot of things had to close down. So this is an overview quickly of recruitment and retention, and it is a measure of reach as well. So in the first cohort, we approached 35 preschools and 11 agreed to participate, which is a 26% acceptance rate. So the reach is not huge. Because of late start and so on, small numbers. 4 intervention, 5 control sites. Baseline data collection was pretty good. Follow-up, as you can see, it's much lower because we get into the COVID period. One site closed because of plumbing issues. Another site closed because of the principal didn't want to participate anymore. This is cohort 2. We approached 83 sites, 17 agreed, although all indications early on were that there was great interest, so 20%. And then we made a change in the design a little bit. We allowed control sites to switch over to intervention if they wished to boost our numbers because we were facing challenges due to COVID. 2 sites agreed to switch over. So we upped our intervention numbers a little bit. And again, challenges in data collection because of COVID-related issues. Here are just a few examples of what we had to change. So the first one here on the left side is we allowed option for control sites to cross over to the intervention condition post follow-up. The second one is major. Our primary outcome was BMI Z-score. Our staff, research staff, were going into the preschool to measure height and weight to keep the research component separate from the intervention. During COVID, of course, we couldn't do that. We still wanted to obtain measured BMI. And so what we're doing now is providing the teachers with equipment, stadiometers, scales, calibrated, and so on, training them and asking the teachers and staff at the preschools to collect this information for us. And they're doing it, hopefully, as well as possible. We moved from in-person to online consent forms and so on, but still found that in this population, many still wanted paper surveys. They didn't want to do things online. And of course, we had to pause our on-site observations by research staff to assess implementation. The next few slides are just very, very quick snapshots of what happens when the coaches go into the sites to provide the intervention. While they're doing that, they're also collecting and documenting information that provides the research staff with implementation assessment. You know, what was actually done, how much, how often, by whom, and so on. So at the level of the site, the coach meets with the site director and they first review policies associated with nutrition, physical activity. And the next one, blue side down, they select the policies that they would like at their preschool to implement. For example, having access to water throughout the day. They agree that at their school, they're going to do 120 minutes of physical activity per 8-hour day, or that they would provide at least 1 fruit and one vegetable or 2 vegetables at lunch. So very specific policies that the schools are going to adopt, and then helping to change the teacher and parent manuals at the school to show these new policies. Here's another example, and this is when the teacher goes into the classroom now at the next level, and the coaches develop what they're calling quality improvement plans that are tailored at the level of the teacher and the classroom to assist the teacher to implement the changes that are in the intervention. So for example, they work with individual teachers. How do I lead as a teacher both structured and unstructured playtime throughout the day? What proportion, what is structured, what is unstructured? How do I integrate it into my day? Or how do I implement family engagement activities now through Zoom. Before they were doing in person. How do I serve family style meals? Not anymore after COVID. And on the right side, this is how the coaches are documenting what they are doing. So for example, some of the schools are listed here, some of the activities listed here, and this provides rich and detailed implementation information. Here's another example. A coach works with the teachers to modify the curriculum. And this is what it really looks like, paper and pencil. And these little columns are activities that the teachers do every day, outside activity, eating time, teaching time. And within each of these activities, how do they integrate nutrition and physical activity content? And the coaches work with the teachers on how to do it, and the teachers document this. So they describe the activity, indicate the source, whether it's the Sesame Street curriculum, whether the teacher did it, did they repeat this, did they make it up? And they also include the associated family engagement activity they did for that. So, paint a banana. So you're painting, you're coloring, you're talking colors, but you're also talking about a banana and how healthy that is, that kind of thing. This is sort of an overall overview of coaching activities. It gives you a snapshot. At the bottom here is a timeline from January 2020 all the way to 2021. And this is the number of activities, and on the right side, sort of the types of activities. And you can see before COVID, a lot was going on. And then starting March, April, sort of downhill. There's a quirk in June a little bit, but then essentially very little going on because of COVID. And there is an uptick now in 2021, January and February. So I hope that this gives you a sense. I try to focus on the implementation aspects versus other aspects of the study. And as we heard before, any outcomes we observe at the level of the child are really a function of many levels of influence. And when you do real world implementation research, it is important to incorporate multiple levels of influence, like we're trying to do in our study. So the parent, the extended family, the preschool, and then importantly, taking the larger community and societal level factors into consideration when you implement the intervention. What is the capacity of that preschool to do what we want them to do? These are not fancy places. So given what they have, what can they do? Lessons learned, stay very flexible. Many compromises are needed, as you saw. Monitor and document as much as possible, including external events, COVID here, but also other things that might happen. The data is often messy, collected by other people. You're relying on that data. We have other trials that we're doing in cancer, in clinical settings. You rely on electronic medical records. They're not as clean as you might think. In this case, a lot of data is provided by the teachers and parents. So it's important not to pin your entire study on a single primary outcome. It is important to have multiple outcomes and try for triangulation if you can. And also at the bottom on the right there, try to analyze data in multiple ways in addition to your primary analyses. For example, we are going to stratify our analyses by weight status to see if we had more influence on the children that started off heavier versus lighter, or vice versa. So this is my last slide, and I'd like to thank you for allowing me to share this with you, and also acknowledge the entire UCLA team, not just the investigators, but our staff and our community partner, CCRC, without whom this would not be possible. And also our project consultants, Ross Brownson and Christine Manson. Thank you.
Dr. Scher?
I should unmute myself. Thank you. So I want to thank you all for this opportunity to present on some ongoing work in Mozambique. This is the Integrated District Evidence to Action Program, or the IDEAS program, which really focuses on improving the routine delivery of evidence-based interventions in the maternal, newborn, and child health space. This is a multi-PI initiative that includes myself and Quinish Fernandez, who is with the Ministry of Health of Mozambique. And what we're going to do today over the next 20 minutes is I'd like to take 12 minutes or so to really just focus on the IDEAS project and evaluation design, and then turn it over to Quinish to reflect on implementation science and its link with policy, really from a public sector leadership perspective. So what underpins the IDEAS program is that globally we have seen pretty astounding reductions in under 5 mortality, including in Mozambique. But these gains have stagnated over the past decade or 15 years, largely due to deaths in the neonatal period. And the figure on the right demonstrates some work from Quinish, which really models out and demonstrates that in Mozambique at a national level, we have stagnated under 5 mortality, largely due to deaths in the neonatal period. Now, the Ministry of Health of Mozambique, like many large healthcare systems in resource-constrained countries, have very strong policies and guidelines that are based on strong evidence around what works. But the application of these evidence-based interventions or these guidelines is uneven across the country and across time. And fundamentally, primary healthcare service utilization continues to be quite high, with over 95% of women having at least one antenatal care consult, over 70% of women having institutional deliveries. Clearly, there's room for improvement, but if we want to bend the curve on under 5 mortality and neonatal mortality, we're really going to have to focus on improving the quality of what's delivered at the primary care level, and to ensure that those Ministry of Health guidelines are implemented as intended with high quality and sustained. So this brings us to the IDEAS initiative, which is built around 2 funded projects. And as I mentioned, Quinish and I are both co-PIs on both projects. And the first is a large investment from the Doris Duke Charitable Foundation's African Health Initiative. And this was the first grant to be funded, where we developed in the intervention, which I'll explain in more detail subsequently. But the intent of this program is to impact or reduce neonatal mortality by improving the system capacity to deliver a package of evidence-based interventions at or around the time of birth. And after funding from the foundation was secured, we applied for funding through the NIH and NICHD through, at the time, the DIRH study section and the Trans-Institute review approach. And the second set of funding, this R01 through NICHD, has two aims. And the first is to generate evidence on the IDEAS strategy. You've heard a lot about the REAIM framework or model today. We're also using the REAIM model to assess the program's reach, effectiveness, adoption, implementation, and maintenance. And we're using a quasi-experimental design, which I'll explain in a bit more detail. And then also in order to provide evidence for the Ministry of Health to guide their decision-making around if, how, and when to scale up the intervention that we're assessing through the IDEAS evaluation. We're conducting an economic evaluation that includes microcosting and modeling health outcomes to estimate the potential budget and program impact from the payer perspective if we were to scale up IDEAS and different implementation scenarios. And what I will focus on today are the first aim of the R1, as well as the design of the intervention itself. So there was talk when Gila first introduced implementation science. She really talked about what is in the center of that pathway from some evidence-based intervention to impact at a patient or client level, and that there is a lot in between that we really should be researching around developing implementation strategies to improve implementation outcomes, like things like the adoption, sustained implementation of evidence-based interventions. So what we are really central to the implementation efforts of this project is an audit and feedback implementation strategy, which is fairly well known in the implementation science world as a dominant implementation strategy, which we have modified and enhanced into a cyclical audit and feedback approach, which starts with facility and district readiness assessments, where we go to health facilities and districts and assess data quality and structural readiness to deliver evidence-based interventions, to look at things like, are trained staff available? Do they have the commodities required to implement the guidelines of the Ministry of Health? And then that goes into a second step of the cycle, which are audit and feedback meetings led by district health management teams, which also includes participation from provincial leadership and external facilitators. And these are carried out twice per year in 12 districts, where every facility in a district presents on their progress in a key set of maternal newborn child health metrics. The performance is reviewed using a secular trend analysis, which leads to development of action plans and then identification of facilities that are low and high performing for continued support. And then in between these meetings or these cycles, we support district managers to provide mentorship to facilities in their districts. And that includes reviewing action plans, providing more clinical mentorship, and then provide facility support grants in order to implement the action plans that were developed in the audit and feedback meetings. And as I mentioned, these are carried out every 6 months, and so that we are able to iteratively build off of gains over time. But and thinking about or looking at where this is being carried out, on the left, you can see a map of Mozambique. We're working in central Mozambique in the provinces of Manica and Sofala, and we're not implementing in all the districts or facilities in these provinces. Have focused on those highest population districts due to resource constraints. But we're implementing this intervention in 12 districts of 25 and 154 facilities in the 2 provinces. And that's about 55+% of the facilities in these districts. But because we focused on the highest population districts, we're covering over 70% of the nearly 4 million people who live in Manica and Sofala provinces. But there's another component to the intervention, or to the Doris Duke Charitable Foundation support, that I'd like to describe. And that is development of implementation research capacity and applying implementation research to help guide decision-making of the Ministry of Health. And so the first element on the left is to work with provincial health authorities across the country and national level leadership to identify key priorities for targeted research. These are small scale, generally exploratory endeavors where there are questions that leaders have around, why do we have particular problems in our province or countrywide, and what can we potentially do about it? And then we support government Ministry of Health research arms to then carry out these rapid cycle research efforts and then disseminate those efforts, largely targeting knowledge translation in country. And on the right-hand side, you can see that there's a capacity building effort as well. And we have been really fortunate to be able to support Ministry of Health leadership to pursue further training in public health or implementation science. And this has included 10 master's level trained officials in country, and then 4 leaders from the Ministry of Health to come to the University of Washington and to pursue a doctoral degree, a PhD in implementation science. And then in addition to that, we have in-service training for short courses for leadership in the Ministry of Health on the nuts and bolts and frameworks around implementation science. It's been mentioned a number of times, the RAIM framework. I'm not going to go into this in more detail, except to say that what I find enabling about the RAIM framework is the ability to look not just at outcomes or at an individual level, or even determinants of impact at an individual level, but to think about those organizational level determinants that are key ingredients for impact at a population level. So briefly, I want to describe what we are assessing as part of this project. This is aim 1 of the R01, supported again through NICHD. And I'm just quickly going to go through some of these domains. The first is reach. Now, as I mentioned, by design, we are not reaching all of the health facilities and therefore not all the estimated pregnancies in Manica and Sofala provinces. So as part of our summative evaluation, we are assessing what were the population coverage that we were able to achieve, as well as the health system coverage that we're able to achieve in terms of reaching with our intervention. Effectiveness starts with a logic model here, quite simplified, articulates why we think our intervention could make a difference. And that includes improving the identification of problems, clarifying what needs to happen and who does it, motivating health workers in the healthcare system, improving their competence to implement guidelines of the Ministry of Health, and then providing that organizational support for health workers to be able to do their work well and high quality. And then that leads to improved individual and team performance, and therefore improved quality coverage of those evidence-based guidelines and reduction in child and neonatal mortality. So we're really using two efforts here to assess the effectiveness. One is looking at the structural and process quality. Do we see improvements in health system readiness and data quality, as well as provider capabilities to implement the guidelines of the Ministry of Health? And to assess this, and this is largely fully being supported by the NIH, we're carrying out repeated annual health facility surveys in 12 intervention districts and randomly selected 36 facilities in those districts, as well as 12 matched control districts where there is no intervention, as well as 36 matched facilities. And then for the population health improvements, we're looking at service coverage of evidence-based interventions and child mortality reductions, using both the health management information system and existing population-based surveys like the demographic and health survey or their multi-indicator cluster surveys. And this has a nationwide scope. Briefly, adoption is looking at the proportion of districts in a facility facilities who adopt our intervention, as well as determinants of adoption, looking at organizational readiness, as well as qualitative appraisal through key informant interviews and focus group discussions. Implementation is focusing on the core elements of our intervention and determinants of implementation, looking both at a routine fidelity to our design through a routine tracking system, as well as repeated CFR guided, consolidated framework for implementation research guided key informant interviews and focus group discussions. And then we're also looking at maintenance, looking at the proportion of districts in facilities that sustain the intervention at 1, 3, and almost 5 years post-introduction. So we hope that by looking at this, our implementation and effectiveness from really a comprehensive 360-degree perspective, we're going to be able to capture not only did we have an effect, but how, why, and what does that mean for future scale up? So I'm going to turn it over now to Kenish. Over to you, Kenish.
Thanks, Kenny. I'm really excited to be here and share my experience from the field. To follow up on what Kenny was saying, I'll try to be practical and speak based on my experience of leading interventions scaling up while I was in a leadership position at the Ministry of Health. I'll give 2 examples to showcase why implementation science really matters. Next slide, Kenny. A lot has been said today about the role of implementation research in closing the no-do gap. However, I want to emphasize that for someone like me who is primarily implementer or in a leadership position, implementation research is likely the most important type of research. I want to acknowledge the role of efficacy studies, but when evidence exists, I believe we should prioritize intervention scale up through existing delivery systems. We know a lot about the barriers that delay evidence translation into policies. Some of them include the lack of stakeholders' engagement throughout the research implementation. Actually, I'll be talking a lot about this, or failing to address relevant policy questions, or failing to disseminate evidence timely. I believe that implementation research is essential because it addresses consistently these barriers. Next slide. Let me now share with you two practical examples. I had the chance to lead the scaling up of two programs in Mozambique, the postpartum hemorrhage prevention through traditional birth attendants, and the provision of contraceptives through community health workers between 2015 and 2017, both interventions at the community level. After the misoprostol acceptability and safety study end in 2010, it took almost 7 years to scale up the intervention to 35 priority districts. The Ministry of Health adopted the results in 2011, right after we end the study, but only in 2017 we were able to achieve the 35 districts. In practice, we sort of delayed the scale up of this intervention that could have potentially addressed one of the main causes of maternal mortality in Mozambique. A quick note here, the TBAs assist almost 30% of the deliveries in Mozambique. On the other hand, it took less than 2 years to scale up oral and injectable contraceptives through community health workers countrywide. The results were available early 2015, and right after that, we started with the scale up. Then why the two programs had different trajectories? Let me assure you that funds availability and high-level support was not the issue. We had resources committed for both interventions, and there was a lot of support from most of the stakeholders working on the MCH. So what made a tremendous difference, at least from my perspective, was the presence in our team of colleagues who had been part of the contraceptive study. They knew what had gone well, they knew what had failed during the study, and they were confident and ready to scale up the intervention. That made a huge difference in terms of speeding up the scale up of this intervention. With the misoprostol, unfortunately, it took time for us to understand and adapt the intervention, as no one from our team was part of the study. We even tried to hire the organization that conducted the study to support with the implementation. But as you can guess, when it comes to scale up an intervention countrywide, no organization, no NGO has the infrastructure to support that. It must be the government, particularly in places like Mozambique, where 95% of the health infrastructure is government owned. So I think that these two examples show clearly why embedding implementation research is critical. Next slide. I want to end by highlighting essential elements, designs of the ideas that can explain, building off the two examples I just gave. First, ideas implementation, as Kenny explained, is led by district and province managers with support from the central level. This helps to create a learning environment and lessons adoptions, particularly at the district level. Second, interventions such has ideas that are embedded within the routine delivery system should be easy to sustain since they have little external support. Finally, ideas has a robust evaluation framework, and that facilitates to understand implementation weaknesses and strength. This is critical to lead the scale up. I guess that was my last slide. I want to take this opportunity to thank the NICHD and the DDCF for supporting the IDEAS program in Mozambique. Thank you.
Thank you all for those wonderful presentations. We will move into a short Q&A session, and our moderator is Dr. Marian Koso-Thomas, who is a medical officer in the Pregnancy and Perinatology branch of NICHD. And I'll let you take it away, Dr. Koso-Thomas. I think you may need to unmute Dr. Koso-Thomas if you're muted.
Hello? Okay, I'm sorry. Talking to myself. I was just saying thank you again for a wonderful presentation. And I apologize for having come this close to the end and not allowing too much time, but as you can see, those are very fascinating presentations. And what I will do is we were hoping to have a rigorous discussion around the question that's on the screen. And because we will not have that time, I'd like to encourage you to look at the chat, because for those of you who have asked questions, some of our speakers have been kind enough to go ahead and respond to those in the chat. And I think some of the key things I've seen come up is the question around resources. And so Gila has been kind enough to put resources up. Dara has mentioned some of our opportunities around training. And I think the question specifically for the speakers on, I believe, Dr. Rasha and Kenneth were not, I didn't notice any particular questions there. So it almost feels like we should have another session, if we can, just to discuss what it is that we're looking at here, because it seems like for everyone who's participating, the question is very clear. How do we then, with implementation research, have the policy impact that we're looking for? So that in and of itself could be a panel. But I think I'd just like to see if I could give the speakers the opportunity to just 1 minute, if you could just give us your thoughts on the question that's on the screen, and what are some of the gaps we're looking at? What are the kind of things we should be considering going forward? Because it's clear to us that we have adaptation, scale-up, sustainability, and de-implementation as the big, key pillars, so to speak. But as researchers working hand in hand with policymakers in order to get that impact, taking several years, just 1 minute briefly, what you may think could be a way forward for us. So I'll start with Gila. Did we lose Gila?
You mean,
Sorry, Marian, I'm here, but don't start with me because I have to run to the airport. I'm so sorry.
All right. Well, just to say that yes, in the chat, Dr. Netta was very kind enough to put resources, and you have the contact information in the invite. So please reach out to us for those who had questions around resources, articles, publications, everything that's coming up that's new, that's different in the implementation science. Please reach out and we'll share those with you. Gila, thank you so much for your presentation today. And I understand if you need to run to the airport. Dara,
sure, no problem. And I'm happy to follow up with any resources or questions. But I think while you have Annie and Roshani on, it'd be great to hear from them. Thanks.
Okay. All right, and Dara, can you just give us just a minute of what you take away from the session today?
Yeah, I certainly would defer to our grantees that are, that are really on the ground doing this work, to, hear from them. But I'll just echo Gila's, I know we're going to make our slides available. There's hyperlinks to all of the resources. But again, I'm also happy to respond if, if people want to reach out. So I don't necessarily have any specific gaps to identify other than, that slide that I showed, at least speaking about the NICHD portfolio. I think there's a lot of wonderful work happening, including what we heard about today, but certainly there seem to be some areas that were less well represented in the D&I space. So happy to chat.
Dr. Bastani, one of the questions that came through, I apologize, there's a question for you. In regards to the language, you mentioned your populations are diverse. And one of the questions that came through was, are you planning on having this intervention in other languages to accommodate the other populations that, have not been involved at this time because of the language issue?
Actually, the preschool is the preschool, and everyone in the preschool is included. So it's not just the English or Spanish speaking children, everyone who's there is included. And the teachers, because this is real world, right? We're not doing the interventions, the teachers are doing the interventions, and they do what they do every day. They teach how they teach in all of the languages. So this is the importance or the difference between an intervention provided by researchers and an intervention that's provided by people in the real world doing what they do every day, all day.
Mm-hmm. And then for Kenneth and Mr. Fernandez, one of the things that he didn't mention was the impact of environmental, Mother Nature issues on the work he's done, and then how that can kind of mess up the work you're doing. And he had a pretty interesting encounter with tornadoes, was it, in Mozambique that disrupted some of your work?
Hurricanes. And I'll let you talk about health system resilience.
Yes, Ken, that's a reality. The two provinces that we are implementing this project are like we used to call the free road for the cyclones. Only this year there were like two events crossing that path. So actually we had the cyclone Idai in 2019 that was category 4. We actually conducted a study on that and we demonstrated services disruption, but more importantly is we have been able to demonstrate quick recoveries after the cyclone, which somehow demonstrates some kind of system resilience. That we can say that the projects that we are implementing somehow are contributing to strengthen the system capacity to respond effectively to these shocks.
Yeah, so I think definitely things like the health equity and resilience are things that maybe we could tackle in another session. And I'd like to thank you all so much, and hopefully we'll have a longer Q&A session next time, but I'll hand it back over to our host, Dr. Lesick and Dr. Walker.
Yes, once again, thank you, everyone. Thank you to our panelists. Thank you for your presentations and all of the wealth of information that you have brought to the table. And thank you to all of the participants, NIH-wide, and all of the researchers for participating in the panel. If you have any questions, please contact the NICHD Office of Global Health, our director, Dr. Vesna Kolesic, at vesna.kutlesic@nih.gov, or I, Dr. Janelle Walker, at jenelle.walker@nih.gov. And just a reminder, the panel presentation and the D&I resources will be made available on the NICHD Office of Global Health website. And please feel free to send any other questions. We will try to answer questions that were unanswered, as well as we will save the chat, and we will have the recording of the presentation. So once again, thank you and have a great day.